Okay, good morning, members. Pursuant to House Rule 10.01, I call this remote meeting of the House Human Services Finance and Policy Committee to order. The first agenda item is to take a roll call attendance. So when Ms. Hanson calls your name, please just unmute yourself, and you may want to unmute now and then say present. Go ahead, Ms. Hanson.
Okay, good morning, everyone. Chair Schultz,
Present.
Vice Chair Bonner,
Present.
Representative Albright, Representative Bolden,
Present.
Representative Burkle,
Present.
Representative Fisher,
Fisher present.
Representative Rydrych,
Present.
Representative Hanson,
Present.
Representative Keel, Representative Liebling,
Present.
Representative Mueller,
Present.
Representative Noor,
Present.
thank you, Representative Novotny,
Present.
Representative Pearson,
Pearson here.
thank you, Representative Pinto,
Present.
Representative Rasmussen,
Present.
Representative Robbins,
Present.
Representative Sandell, and Representative Schumacher.
Schumacher present.
Thank you.
Okay, members, we do have a quorum, and I just need to entertain a motion to approve the minutes from yesterday, January 13th.
Madam Chair, I'll move the minutes.
Thank you. Representative Bonner moves the minutes for January 13th. Is there any discussion? They're very simple minutes. Make sure your name is on there if you attended. Hearing no discussion, all those in favor, unmute yourself and please say aye. Aye.
Aye.
Any opposed? Okay, the motion prevails. The minutes for January 13th, 2021 are adopted. So today, members, we have two presentations. The first presentation is from MDH, Commissioner Jan Malcolm, and we're going to talk about, we're really going to focus on long-term care today. So I just want to set the stage that I know a lot of you have an interest in long-term care. It's an important topic. We want to spend as much time as we can fixing what problems we have, identifying the problems, and also highlighting what we're doing really well in long-term care. But we are going to talk, there are slides that discuss vaccinations, and I know many of you are getting a lot of questions from the public about the vaccination distribution and rollout. Representative Chair Freiberg had a committee hearing about that earlier this week, and I know Chair Liebling is going to have a hearing on the vaccination distribution plan next week. So I want to make sure we're focusing today on our long-term care strategy, and I don't want to spend a lot of time on the vaccination because there is so much right now in flux. And the best thing we can do as members right now is make sure we're providing the resources that MDH needs to meet the demand and to really start tackling a very complex issue of rolling out mass vaccinations. So our job as members is to get the information out once a plan is in place to the public, to our constituents, and make sure we're providing the resources and tools MDH needs so they can be successful in rolling out mass vaccinations once we have the supply that we need to do those mass vaccinations. And I'm going to hold my comments on the other presentation, which is about long-term care. We're going to have a presentation from Cheryl Hennen from the long-term care, excuse me, Ombudsman's office. So I know that Commissioner Malcolm has a hard stop at 11, so I want to get right into it. But first, I know that Representative Albright also wants to make some introductory comments. Go ahead, Representative Albright.
Thank you, Chair Schultz. Speaking for the GOP caucus, I know that the job that Commissioner Malcolm has undertaken has been incredibly strenuous, has been incredibly divisive at times based upon, what side of the opinion you are at. But I would urge members of this committee to refrain from questions relevant to the COVID pandemic and the response that this state and her agency has put forward. As one of my mentors said, Tony, there's a day and a time for these questions, but today is not that day. Rep. Schultz and I have discussed this matter at some length, and we have a commitment between each other that this topic will be coming back to this committee very shortly. Given the nature, as Representative Schultz has said, the fluidity of the situation with new federal regulations and our response to them not being hammered out yet, I think it's incumbent upon us to not speculate and prepare for when they have more firm understanding of how those affect the response and the dissemination of the vaccine. So I look forward to the presentation, Commissioner Malcolm. And as always, we always wish you the best in your efforts to provide services to people across the state. Thank you, Chair Schultz.
Thank you, Representative Albright. We really appreciate those comments and that feedback. So I just want to remind members today, think about long-term care and questions you have for the long-term care area. And if you're interested in working on this area, please contact me, or if you're working on bills, we're very interested in learning about what your interests are and how you can meet the needs of your community. So I'm going to open it up to Commissioner Malcolm to start her presentation. And remember, members, you can observe the committee hearings, even if if you don't serve on that committee. So I know Chair Liebling is always open to having members observe her committee hearings and then follow up with questions afterwards to the agencies or to our leads. So go ahead, Commissioner Malcolm.
Thank you, Madam Chair, and thank you also, Representative Albright, for your kind and wise words there. I appreciate that very much. Good morning, members. Jan Malcolm, Commissioner of the Minnesota Department of Health. Our intent today is to focus on the long-term care component of the COVID response. We certainly can and will talk with members at any time about the broader COVID response, but as Representative Albright said, today's focus is really on the long-term care component. And we will just give you kind of a context setting of where we are with vaccination, but as Madam Chair and Representative Albright indicated, much is in flux, and we will have a lot more to say about the specifics of our next steps in the coming days, and look forward to briefing you on that. I'm going to go really quickly. We want to save time for your questions, and you have these slides available to you, so I'm not going to linger on each one, but welcome your questions at any time. The overall goals of the COVID response since the beginning, and it was just about a year ago now that we were becoming aware of the fact that the virus that began to be visible in China had already begun to spread around the world and in the United States. It's amazing to me to think about all that has happened in the last year. But from the beginning, we knew that our goals were going to be to we didn't think it was possible to keep COVID-19 out of our state, of course, but we wanted to slow down the rate of growth in the pandemic in order to certainly prevent as much health harm as possible, both deaths, of course, and long-term health problems, but also how critical it would be, having seen, early on what was happening in Seattle and Europe and elsewhere. To manage the rate of growth is key to avoiding overwhelming the healthcare system. But all along too, we've been painfully aware of the negative impacts of the pandemic on society more broadly, on businesses, the economy, and well-being of our people. And we wanted to. I'm amazed, and we all should be proud of the fact that less than a year after this virus was identified, and that we had the whole genome sequence, we've got 2 approved vaccines that allow us to go on offense in fighting this pandemic. Our goal all along has been to kind of bridge to the day when vaccines would be available, and we're there now. But as we as we know, and we'll talk a lot more about, just the reality of the vaccine supply means that it's going to be a process and a many-month process before we can get enough people vaccinated to put this pandemic behind us. Next slide, please. We have had some key strategies all along, including focusing on, special focus on those most vulnerable to severe illness. And of course, we have since early days known how important it was going to be to focus on long-term care. Next slide, please. So we've known since the beginning, I think my first committee testimony was in late January in 2020, that long-term care facilities were going to be at elevated risk just by very nature of the population and of what we already knew about the virus. That older people with underlying medical conditions are more susceptible to severe courses of disease and mortality than the general population, and really significantly so with this particular virus, as we've learned more and more as time has gone on. And the very nature of congregate settings, it creates conditions for spread. That's true with all kinds of infectious diseases that are more prevalent in long-term care settings than elsewhere by virtue of just the very settings themselves. And of course, this committee knows well, there have been systemic challenges with the long-term care industry for a long, long time. Staffing shortages have been endemic in this industry. Turnover, just level of staff available, all of these things far predate the pandemic, and the pandemic has worsened them by orders of magnitude. Next slide, please. So we started early on with some special focus on long-term care facilities. We stood up a statewide healthcare coordinating center that early on started having a lot of interaction with the long-term care provider community, setting up a call center early on. And we're talking now like January, February, to connect facilities with needed resources and beginning quickly to try to understand what were the testing resources that we could bring available to long-term care. Next slide, please. So again, that started really early on. In March and April, we were doing weekly calls with the provider industry. We set up a special response team at the health department that each facility that had a single case was assigned an MDH case manager to help them. We sent teams in person and virtually to help with infection control, to do consultations. We brought a CDC team in twice to advise us on best practices in working with long-term care. And we established a process for facilities to request personal protective equipment from the state warehouse because they were not eligible for supplies from the federal strategic national stockpile, which were reserved for hospitals. And then the strategic national stockpile was essentially emptied after the first couple of pro rata ships out to the states from that federal stockpile. So building up the state stockpile was an early and important strategy. Remember back in March and April, testing was in terribly short supply everywhere. And we were testing, and the state public health laboratory was the only laboratory doing COVID testing for quite some time. And we had capacity to do about 2,000 to 3,000 tests a day, just given the supply limits in the testing ecosystem. So that was March and April. And so nobody had access to the testing that was needed back then. Then in May, next slide, please. The governor, and we had some really tough learning in those first months, really tough learning. Some facilities were hit early and hit hard with significant outbreaks. And we quickly discovered, the difficulties in accessing PPE, the inadequacy of testing. So we learned some hard lessons early on. And the governor asked us to kind of put those early lessons to work and to scale up our focus on long-term care, and had sort of five points to this focused plan to expand testing specifically for long-term care, to set policies that made it clear that testing needed to happen anytime a facility had even a single case or 2 people with symptoms. So setting a policy guidance that testing had to happen, but then not just telling the facilities you have to do this, but helping them do it, build the support and the troubleshooting and the supply chain to enable more testing, getting PPE out to those facilities, and helping them with staffing challenges, even for the hardest hit facilities, and then to make sure that we were doing a better job of linking long-term care facilities with local support through their health systems and local public health. At this point, I'm going to turn it over to Assistant Commissioner Diane Rydrych to kind of give you just a very quick kind of progress report on sort of the performance metrics in each of these aspects of our long-term care strategy, specific again to COVID. And then Diane will also comment briefly on another really critical piece of work, how we're doing on implementing the assisted living licensure law that you all helped us pass a couple of years ago. So with that, Madam Chair, I'd like to turn it over to Assistant Commissioner Rydrych.
Thank you, Commissioner. Ms. Rydrych, please begin and welcome to the committee.
Yeah, thank you, Madam Chair and members of the committee, and thank you, Commissioner. For the record, my name is Diane Rydrych, and I'm the Acting Assistant Commissioner of the Health Systems Bureau at the Department of Health. And with the Commissioner's context setting, I'll just jump in on, there we go, slide 8, thank you. So I'll just note, when we talk about testing in long-term care, it's really not just about the work of running the test in the lab. You know, the Commissioner noted the early constraints on testing and the fact that it was really just the public health lab that was doing it initially. And we were just getting to a point at the beginning of May where testing was more available through Mayo and the U of M and some of the other labs around the state. But the biggest challenge in a long-term care setting with testing is getting all of the logistics in place to get a team on site to collect specimens from residents and from staff, getting consents in place, getting insurance information when that's needed, making sure the supplies get to the right place. So back at the point when the battle plan began, we stood up teams to handle that scheduling and logistics function, to be able to get the people there for specimen collection and the supplies to the right place at the right time. We developed toolkits, we developed FAQs, consent forms, registration forms, rosters, and a lot of guidance to just help facilities understand, how do you prepare for this? You don't want to have a team show up and the facility hasn't informed their residents, hasn't talked to their staff, hasn't talked to family members, hasn't thought about cold storage for specimens after they've been collected. So there are a lot of those pieces that have to be in place. And we spend a lot of time setting up that infrastructure to allow it to happen smoothly and with no barriers. We also set up at the time a standing order. Most nursing facilities all have a medical director who can order tests for residents, but a lot of assisted living facilities don't. And a COVID test requires an order. So we set up a standing order for facilities to use, and Dr. Ruth Linfield from the health department is the ordering provider in those situations. So that gives those facilities the ability to smoothly order tests in situations where they would not otherwise be able to. We also set up a nurse line to communicate those results back to facilities. So they can call or text to the individual or to the facility to let them know what the test results were. As you know, we used the National Guard very heavily at the outset of the battle plan. There were National Guard teams that were mobilized in early May, and they formed the backbone of our specimen collection and testing efforts throughout much of the summer while we transitioned to getting contracts in place with health systems and provider groups and staffing companies who could go out and do that specimen collection. Next slide. Thanks. So from the point in the spring when we were only doing 2,000 to 3,000 tests a day statewide, at this point, a significant percentage of the testing that happens each day is in long-term care. So over the 6 or so weeks at the end of the calendar year, the number of PCR tests being done in long-term care each week ranged between 45,000 and 70,000 per week. So imagine that from our starting point of 2,000 to 3,000 tests per day statewide. Now we have up to 70,000 at its peak tests being done just in long-term care, and that's just PCR tests. There are also point-of-care antigen tests that facilities have received from the federal government, and we think there are, in the peak weeks, there have been as many as 10 to 15,000 antigen tests done at the same time. A lot of that volume and a lot of the fluctuation is driven by CMS requirements for testing of skilled nursing facility staff at frequencies that are driven by the county level positivity rate. So as a county has more COVID and a higher positivity rate, the staff have to be tested twice a week. When those rates come down, they can test once a week, or in some cases even once a month. So that drives a lot of that. Over the last couple of weeks, as the county rates have declined, we now see most facilities testing their staff only once a week, and these volumes have dropped from 70,000 at the peak in early December back down into the 35 to 45,000 tests per week range now. So the team that we set up at the State Emergency Operations Center, or SEOC, back in the spring and summer, now coordinates about 10,000 tests per week at about 100 facilities. The rest of these tests are coordinated by facilities directly. So we worked with long-term care facilities quite extensively over the summer to help them understand how to get a connection in place with a lab, whether that's Mayo, the U of M, Health Partners. Some use out-of-state labs, but we wanted them to be able to use our resources and our teams as kind of a safety net or as a bridge until they were able to get those relationships in place themselves. And most of them now do that, but if they need help, they can come back to that SEOC and we will send a team out to them and we will arrange for supplies and the logistics for testing for them. By the end of the calendar year, we at the SEOC and those connections that facilities had made, the SEOC teams had swabbed 883 unique facilities and almost 270,000 individuals. The number of individuals is not unique because a lot of people do get tested more than once, but our teams and that infrastructure that we stood up ended up going out to nearly 900 facilities over the course of the year and doing specimen collection for them. Next slide. So I'll talk just really briefly about a couple of the next slides and just note that, and the commissioner alluded to this, we provide case managers to every facility that have a case. We have teams of infection control professionals who go out to facilities or can do remote infection control guidance and provide support to them to improve their infection control practices. We continue to provide toolkits and FAQs and other things to support facilities in understanding the evolving kind of state and federal landscape around testing. Over the course of the pandemic, our case managers have assisted around 1,600 skilled nursing facilities and assisted living facilities, and close to 350 facilities have gotten infection control focused consultations. Next slide. So I think we'll skip this slide and move to the next one, which just provides kind of a summary on PPE. Again, the commissioner noted that in the early months of the pandemic, we were really constrained in PPE, and we're at a point where we could only provide to facilities when they were very close to running out because our supplies were so limited and the long-term supply chains were uncertain. But we've gotten to a point where over the course of the pandemic, we have sent out more than 9 million gloves, more than 100,000 N95 masks, more than 350,000 gowns to long-term care facilities over the course of the pandemic. They can still request PPE when they need it. The number of requests has declined significantly in recent weeks, but it is still an option for them to come to us and request what they need. Next slide. Really briefly, I'd like to talk about staffing because this has really been a critical focus area for us over the recent weeks. As COVID spread, as county positivity rates increased, we had a number of facilities that would suddenly be facing staff crises with multiple staff out at one time, either due to a diagnosis or for isolation and quarantine. We encourage facilities to try and solve the problem locally using a staffing company, using a sister facility, et cetera. But if they need help beyond that, we have a database of health professionals, the ELADTech database they can use. We have used National Guard teams to go out and provide care on site. They've been trained as CNAs, and we've had federal teams who have gone out and provided those supports on site as well. Next slide. So the commissioner talked about this. You know, staffing has been an issue in long-term care far before the pandemic. These are often lower wage jobs, especially relative to positions that nurses could get in other settings of care. Relatively poorly paid, very physically and emotionally demanding. And now with COVID risks and perceptions around safety really exacerbating that, it's been incredibly difficult for many facilities to find staff during the pandemic. Next slide. So I'll wrap up in just a moment. So just an overview of staffing supports we've provided, either via placement of National Guard or federal teams, often for a week or up to 2 weeks until sufficient staff are back at work, and facilities that have been supported with the ELADTech database. And this is as of late December. We are very pleased that the number of facilities needing our support has declined precipitously as case rates went down towards the end of the year. Before the Christmas holidays, we were supporting upwards of 50, close to 60 facilities at any one time who were just getting consultation or crisis staffing manager support or having a team on site. The number today was 15, which is lower than it has been in several months. If we could jump ahead to slide 17. I think you all know this. I'll touch on it really briefly. Some of the biggest challenges with this work have not been about the technical aspects of testing or staffing, although that is challenging, but it's about finding the right balance between protecting vulnerable seniors from the risks of a virus, which are severe for them. Outcomes for vulnerable older individuals who do get COVID can be far more serious than for someone else. But if you overbalance and you work too hard to protect them from that, you can create barriers that isolate them and keep them from getting some of the much needed support that they need from their families and their loved ones and essential caregivers. And that creates its own emotional and physical effects. So the guidance on that has evolved over the course of the pandemic at both the state and federal level. Currently, facilities that don't have an outbreak within the last couple of weeks and that are in counties with positivity rates below 10% do have the ability and even the obligation to allow visitors. So I think we're in a good place in terms of providing that balance where if an outbreak is active in a facility, there are more restrictions, but once that outbreak has stabilized and there are no new cases within the last couple of weeks and the county level positivity has come down, facilities are able and encouraged and even required to allow visitors in. Really briefly, slide 18. I think this is helpful to see long-term care outbreaks in the scope of the overall pandemic over the course of months. The big curve that you see, the gray line, is the overall number of cases in Minnesota, and you can see the significant surge that we experienced in the fall, and then the smaller one in the spring. And the blue line is cases in long-term care. The work that we did over the spring and the summer and the hard work that facilities did over that time period really helped us to keep cases down, even as the surge was happening overall in Minnesota. But at a certain point, those flood walls are insufficient. And as community spread increases, as the number of cases and percent positivity in each county surged in October and November and into December, we started to see those flood walls being breached, and we started to see more cases happening in long-term care. Next slide, and then I'll skip a little bit ahead. This is just really briefly, I think many of you have seen this slide before. It's the best apples to apples comparison that we have, looking just at skilled nursing facilities, which are federally regulated state to state. You can see where Minnesota ranks, and I believe we're 31st or 32nd on this slide. Just in the interest of time, knowing the commissioner has a hard stop, we'll skip over the next 2 slides and go to 22. But you have the slides for your reference. So really briefly, I wanted to provide one quick non-COVID long-term care update. As many of you know, the legislature passed critical transition language during special session to allow us to move into the implementation phase for the new assisted living licensure process that will begin this summer. And that was consensus language that was worked out with a very wide group of provider and consumer advocacy stakeholders. It will greatly ease the implementation process, both for us and for the facilities and organizations who are subject to the licensing requirement. And we really appreciate the legislature's work on that and continued leadership. There will likely be some smaller tweaks to the language that may come forward this session. We have begun a stakeholder engagement process with that same wide group of stakeholders, and we are all committed to only bringing changes forward if there is consensus on them. And we are talking with staff about one small drafting issue that needs to be addressed from the transition language. And just finally, I'll note that alongside the statutory changes for implementation of assisted living licensure is the rulemaking process. And the next step in that is the public hearing for assisted living licensure, which is happening over the course of 2 full days next week. And that's where the general public, stakeholders, others get a chance to provide direct input, comments, feedback, in addition to the written comments that they've submitted on the proposed rule, and have a chance to get that aired in front of a judge in a public hearing space. And we're looking forward to those 2 days, and appreciative that we've gotten to this milestone. So I will stop there so that there's a little bit of time for questions.
Thank you. Thank you, Ms. Rydrych. And I was I'm very familiar with the process that we went through for assisted living licensure, and it was a bipartisan effort, and it was really impressive at how MDH and their staff really stepped up and got all of the stakeholders together and met hundreds of hours to get that implemented, and they're still meeting and working through the rulemaking. But we're going to have another committee hearing on assisted living licensure and an update. So if members want to hold those questions for next week, and we'll have another committee hearing about that. So I know Commissioner Malcolm has to leave soon, so I'm going to entertain questions from our members about the slides that were presented. And I see Representative Albright has a question. Go ahead, Representative Albright.
Thank you, Madam Chair. This is for Assistant Commissioner Rydrych. On one of the slides, you talk about the number of facilities tested at least once. But in the next slide, you talk about a large number, almost twice as much, 1,600 in terms of skilled nursing facilities. I'm wondering, with the number of facilities, and that's the question, is you say just short of 1,000 facilities have been tested, but how many haven't been tested?
Ms. Rydrych?
Yeah, Madam Chair, Representative Albright. I don't have that number offhand, but I'm going to guess that it is quite small. The 883 that's noted on that slide, I don't have the number of the slide here, but it might be around number 9. The 883 facilities that have been tested are the ones that we have coordinated through the SCOC. So they've worked with us to have a team either from the National Guard or from a health system, et cetera, come out. But many facilities don't go through us now. Either they're part of a corporate chain and they've been able to arrange for their own testing, or they've just managed to do it directly with a lab. So there are quite a few more than that have done testing, but it was not coordinated by us. And we know that the number of facilities that have had a case is significantly higher than 883. So we can go back and look at our data and see if we can get to a good number among the skilled nursing and assisted living facilities that have not been tested. But it should be a pretty small number.
Representative Albright?
Thank you. Just one quick follow-up, Assistant Commissioner. You show a slide late in the deck with regard to cases for LTCs versus the general population. It's fairly obvious the disparity between the number of cases and the mortality between LTC installations, if you will, and the general population. I'm just wondering if we would see a similar dramatic decline in that from a mortality perspective in LTC versus the general population. And maybe that's something that if you could generate that and provide it to us, I think that would be helpful in terms of appreciating the context with which the cases are being purported. So I'll leave it at that. But thank you very much for your presentation, both of you.
Thank you, Representative Albright. Assistant Commissioner, did you want to comment on that?
Yeah, Madam Chair and Representative Albright, thank you. Actually, one of the slides that I glossed over, two ahead of this one, shows the percentage of all of the, ahead, yeah. Next one shows the percentage of deaths that were in long-term care settings compared to overall. And here too, you do see that pattern where early in the pandemic, we had 80 or so percentage of the deaths in any given month were happening in long-term care. And that has reduced as a percentage over the course of the pandemic. And it's been hovering around 60% for the last few months now, as the number of cases and the number of deaths has spread as part of the overall pandemic. We have seen relatively fewer as a percentage of overall mortality that's happening in long-term care.
Thank you, Assistant Commissioner. Representative Albright, did you have one more question? Your hand is up.
No, Madam Chair.
Thank you. Representative Rasmussen.
Thank you, Madam Chair. My question is for either the Commissioner or the Assistant Commissioner. On page 19 of the presentation, it shows Minnesota, well below average in terms of the resident cases that we have per 1,000 per the CMS data. But if we look at page 21, we're above average when it actually comes to resident deaths. And I was wondering if you could offer some explanation as to why we see the differences between those two numbers. Thank you.
Thank you. Commissioner?
Thank you, Madam Chair. Representative Rasmussen, great question. I will point out that this is a weekly chart. So this is not the cumulative results over the whole pandemic, but where we are in a given week. And I'm sorry, I don't have the date reference on this particular chart, but it's as Assistant Commissioner Rydrych mentioned, what we saw building through October and into November and December as cases reemerged and reemerged fairly significantly in long-term care, driven by staff being exposed to COVID because the community spread was just so rampant, bringing the cases back into the facility. That's when we saw an uptick again in cases and in deaths. In terms of, and I don't know if Assistant Commissioner Rydrych has anything else, on your more specific question about why do we do better on cases and less well on deaths? That's certainly a question that we are asking ourselves as well and trying to dig into these to this number. So let us come back to you with a little more explanation on that dynamic from the perspective of some of our epidemiologists who weren't available for this morning's hearing, but it's a really good question. Diane, do you have anything more that you would add at this moment?
Assistant Commissioner Rydrych?
I don't. I think it is best to take that back to the EPI team and see how they would answer it. I don't know if there are differences between Minnesota and other states in terms of how our skilled nursing and assisted living populations break out. In a state where maybe there is a more extensive set of alternative types of care settings for facilities like for individuals like assisted living, you might see perhaps a sicker population being in nursing homes relative to other states. I do not know if that's true here, but that's something that we could take back to the EPIs and see if they have a better answer on it.
Yeah, I think our state has done really well at making sure we're avoiding nursing home and, keeping people at home longer and giving them the resources they need. But we'll explore a lot of those topics this session. I think Chair Liebling has a question.
Well, thank you, Chair Schultz. I was just going to chime in and suggest the same thing that Ms. Rydrych did, that you have to make sure you're comparing the populations appropriately. And we don't really have, I've asked this very same question because in Minnesota, we do really well at keeping people out of skilled nursing facilities. And we've worked on that for years. And since I have been in the legislature, which is now, 16 years, it was always, look what a low percentage of our population is in skilled nursing. And what that probably means is that those people are sicker and probably older than perhaps populations in other states. If so, I'm, surmising that is the reason, and it would be really interesting to see if we can possibly get real data on that, but I think it's going to be very hard to get.
Yeah, in my day job, I look a lot at selection issues, and we have some really great experts in our country working on long-term care and selection in economics. And Representative Rasmussen, I'll send you some information about that can explain that selection issue. Are there any other questions from members before Commissioner Malcolm needs to sign off? I'm not seeing any. Well, thank you, Commissioner Malcolm, for joining us. We appreciate it.
Thank you so much, Madam Chair and members. We will look forward to briefing you on vaccine issues. I think there are some slides in the deck that you can look at your leisure that just sort of explain the basic scheme. But the big news of the week, obviously, is the very significant change in direction from the federal government, that rather than taking quite such a staggered approach to prioritization, that we're given permission and encouragement to move more quickly to expand vaccination into the broader population beyond long-term care workers, beyond healthcare workers and long-term care residents into the broader over 65 population and people with underlying medical conditions. That is good news. The challenge, of course, is that the supply of vaccine needs to also expand quickly in order for us to be able to vaccinate larger groups of people in an orderly way. So that's what we're working on right now. We'll look forward to briefing you more extensively in other committees and in this one as you wish in the coming days. So we had been planning for this expansion, but we were planning for it, to happen 6 weeks from now, not immediately. But that we consider this to be a good development, with the big caveat that the supply needs to increase rapidly to help meet that expanded public expectation. Thank you very much for your time this morning.
Thank you. We look forward to getting that update and getting that out to our constituents. And I know you're doing a lot of work. We want to let you go so you can do that work and have time to do that. And we will see you probably next week sometime. Thank you, Commissioner Malcolm.
Thank you again for your time, members.
And thank you, Assistant Commissioner Rydrych, for joining us as well. So our next presentation is from Cheryl Hennen. She is the Executive Director of Long-Term Care Ombudsman's Office. So if we want to upload her slides. And Ms. Hennen, do you want to introduce yourself? Welcome to the committee. Thank you for joining us today.
Good morning, Chair Schultz, and thank you for inviting me. I am Cheryl Hennen, the State Long-Term Care Ombudsman. I have met some of you and appreciate spending this time with all of you, and look forward to touching base with all of you. I also want people to know you will have my contact information, and I'm certainly open to connecting with you at any time. Next slide, please. This slide contains the mission statement of the Office of Ombudsman for Long-Term Care. Also, you may have received an electronic copy of our brochure. And I assure you that I take very seriously the fact that we do work to enhance the quality of life and quality of services for people who receive long-term care services. And we do that through advocacy, education, and empowerment. Next slide, please. So here's a brief history. It could be a full day type of in-service, but this gives you a snapshot. I started with the office in 2004. I worked in the region. I had an assigned region within the metro area. And I have to confess, prior to coming to the office, I myself struggled with even correctly pronouncing the word ombudsman. And throughout my career with the office, it's very clear how important it is that within the Older Americans Act, enshrined is the mandate for an ombudsman program to be in every state. And as you can see, this goes all the way back to the term ombudsman goes all the way back to the year 1809. Without reading every word on the slide, I wanted you to know, where did this start? Well, basically started within President Nixon's administration, where Dr. Arthur S. Fleming, who served as the Commissioner on Aging, was very clear about the concerns of the conditions, the very deplorable conditions at that time within nursing homes. Ombudsman program started as a demonstration project. There was enough success to shift to establishment of expanding the program. And as I mentioned earlier, in 1978, amendments were added to the Older Americans Act that every state should provide ombudsman services. Next slide, please. Legal authority and governance. The long-term care ombudsman program is a program of the Minnesota Board on Aging. We advocate, we serve residents living in long-term care settings, which includes nursing homes, assisted livings, certified board and care homes, the Minnesota Veterans Homes, and Medicare beneficiaries receiving services in their home. So we do have a defined scope of authority. For those of you who are interested in reading where in state and federal law all of the ombudsman program mandates exist, I give you the citations. As I mentioned, we're administered through the Minnesota Board on Aging. The Board on Aging is my governing board. This is a 25-member governor-appointed board. My office, the central office, is in St. Paul, 3 blocks down from the Capitol. It's in the Department of Human Services building, although the program is not a program of the Department of Human Services and must not be. This is part of federal law. We must not be a part of any entity that provides services or regulates services. So, but every state must establish a state unit on aging. In Minnesota, it is the Board on Aging, and the administrative support is provided by the Department of Human Services, which, by the way, in most states, this is a common structure. We do have regional offices throughout Minnesota, and we also have certified trained volunteers. Next slide, please. This slide shows you what type of funding sources the Ombudsman Office has. So you will see 47% of our funding comes from the federal government. 12% is CARES Act funding. 35% is state funding. The green, if you are able to see that shade of green, 2% of this is, I have listed MHM, that stands for Moving Home Minnesota, which is really money follows the person. And this was mentioned earlier as Representative Liebling talked about the fact that Minnesota is quite a front runner for making sure that we provide, or that we have people's choice primarily be living within their homes, within their communities. The money follows the persons is a rebalancing funding, rebalancing long-term care services for the community. And in Minnesota, Moving Home Minnesota is within the Community Supports Administration. We were approached by this entity to work to develop a self-advocacy curriculum for residents living in long-term care settings. This curriculum is designed to not only educate people on rights specifically related to living in lesser restrictive environments, but also to understand what it means to feel self-empowered. So the the 4% is RFACE. And what does RFACE stand for? RFACE stands for Resident and Family Advisory Council Education. Minnesota Statute 144A.33. If you were to look that up, this is the statute that directs funding to the Minnesota Board on Aging to provide education to resident and family councils. And within the statute, it does list the entities that should receive this type of education from our office and what those educational topics may look like. This funding is, we garnish this funding from, there's a $5 charge per each active nursing home bed in Minnesota. And that is what makes up the RFACE funding directed to our office. Next slide, please. Oh, before we go there, I am so sorry. Can we go back? Thank you. I want to acknowledge the 35% state appropriation, state funding. So you will see, because of the support from especially members of this committee and others in the House of Representatives and senators in the Senate, today I will be talking about the state budget appropriation. So I wanted to acknowledge as a preempt to what you will see in slides to come. Next slide, please. Person-centered client advocacy. The Federal Older Americans Act mandates that residents have access to advocacy services on a regular basis, in-person presence. We are very unique. We are what I will call the boots on the ground, your boots on the ground. I am here to represent the voice of residents in long-term care settings, and much of what I share is based on the investigations. We do investigate and resolve complaints that relate to the health, safety, welfare, and rights of residents. And what you will see is there is no income screening, there is no citizenship requirement, no referral requirement, and we welcome calls from residents, family, friends, facility staff, and others. And it's a free service. Also, this slide does indicate for you what the Older Americans Act actually mandates that we do, including making recommendations to state and federal agencies, to the legislature, to Congress, and to others to improve the quality of life of residents. I do serve and represent Minnesota at a national level and have also the opportunity to provide input at the congressional level. Next slide, please. So here are facts important to remember. What do we not do? So the regional ombudsman staff, including people in state office. So the state office staff is made up of myself. I do have 2 deputies, as well as policy specialist, a data specialist, and a volunteer coordinator. So what we do not do is we do not conduct licensing and regulatory inspections or investigations. However, we do provide input to licensing and regulatory inspections. What that means is the surveyors from the health department, prior to going in, they contact our office and we provide information. We do not perform adult protective services or investigations or provide direct care to residents. I want to specifically focus on the right to confidentiality. So many people, when they contact our office, They fear if they report, they fear retaliation. They want to remain anonymous because most often, unfortunately, they are reporting bad things that have happened. What's very clear in the Older Americans Act and within our regulations is a strict adherence to disclosure of Ombudsman program information, disclosure of resident identifying information, as well as if the person who is filing the complaint is a representative of the resident because they are unable to speak for themselves. And also, what's important for people to understand is we are exempt from mandated reporter responsibilities. For what reason? It's for this reason. In order to protect the identity of individuals. Of course, if someone were to give consent, we would do that. And there are specific provisions within law that allow us to report abuse in certain situations so that you understand we would not be complacent and turn our backs to abuse should we be aware of it. Next slide, please. So here is where I want to focus on a certain, the Elder Care and Vulnerable Adult Protection Act 2019 legislation, I believe was one of the most important pieces of legislation that Minnesota worked together on to make sure would include very important provisions of resident rights, for resident rights. We all know that Governor Walz signed this legislation May 22nd of 2019. So many great things exist within this package. What I will focus on today is the package did include increasing staff to the Ombudsman's office. I want to share with you that the national ratio for ombudsman, one ombudsman to, and they use the active bed terminology, the national average should be one regional ombudsman to 2,000 active beds. That's part of a study that was conducted in order to arrive at that recommended ratio. Prior to the budget appropriation, we were at 1 to at least 9,000. How do you make sure presence is available? How do you make sure advocacy services are available at 1 to 9,000? You will see on this slide that I do provide our contact information. We do have 3 people who are live answering intake calls every day. I want to, next slide, please. Okay, so this is every number represents a regional ombudsman location. This is pre-budget appropriation, Greater Minnesota. There's 9 numbers on that map. Next slide, please. Here's the metro area, pre-budget appropriation. Very, very dense part of our state. 5 locations. Next slide, please. I am so proud to share this slide with you. This is current. It was my goal that we would take our budget appropriation money and invest it back into our communities, back into our region, the boots on the ground, the people in the facilities, to the greatest extent possible that I was able to do so, to reinvest back into reaching our people. That is what you wanted me to do, expected me to do, and we're doing this. We're doing this during a pandemic, during a hiring freeze, by the way. I did seek exemptions to the hiring freeze. I obtained them, and we are moving. Current Greater Minnesota map. Next slide, please. And here's the metro. So what we have been able to do The budget appropriation included 9 regional ombudsmen and 1 deputy. So we have 1 more regional ombudsman to hire, and that will be in the Rochester area, and we will have fulfilled that particular responsibility of the budget appropriation. I am just so grateful to all of you legislators who supported this budget appropriation to expand advocates throughout the state of Minnesota. The budget appropriation also included 1 full-time employee to work on electronic monitoring and other ombudsman legislative activities. As you may know, within Minnesota law now exists the right to electronic monitoring. Also, the budget appropriation included 6 additional support staff. So as I told you, I've added staff on the intake line for being live, hoping that we can reduce the number of calls that are missed or go to voicemail. We're also working on more staff to accommodate support to the regional staff. Next slide, please.
I'm going to stop you there, Ms. Hennen. We have a question from Representative Keel. Did you want to ask your question now, Representative Keel?
I can now, or wait until Cheryl's done.
It's up to you, Representative Keel.
Okay. Well, she answered part of my question earlier. I was wondering, you know, how easily it has been in this hiring freeze or this hiring situation to be able to find people. And it seems like you're not having trouble with that. Is that what I understood, Ms. Hennen?
Ms. Hennen?
Madam Chair, Representative Keel, hello, by the way. So as people get to know me, I'm very persistent. I will not stop. And so we have compelled we've went through our process, we've obtained our exemptions to the hiring freeze. And what is so amazing is the number of people who have responded, particularly to applying for regional ombudsman positions. I've had some less amount applying for policy position or the electronic monitoring. And I'm glad that you asked the question, because it's very important to me to also expand the diversity within our office. And so we have also paid close attention to equity and inclusion. So I'm grateful. We have not had much trouble with the hiring pool.
Madam Chair.
Yep, Representative Keel.
Thank you. I'm glad to hear that, because with all the difficulty in hiring, and I can see where this might have been a problem. And I would like to share with you, Cheryl, and actually the committee. We talk about all the stress that gets called in, the icky stuff that gets called into the Ombudsman's office. But I want to share with members that we went state to state. I had the family in my district and the parents in Albert Lea, but they were separated. And during COVID, could not see each other. They were going to be celebrating their 60th wedding anniversary. And while the Ombudsman could not get them together on the day of their anniversary, they are now in the same building. And the family was just very relieved at the work that you did, and very appreciative of the fact that you and your office and the Ombudsman in that area was able to be successful. And I just really appreciate that, because, you know, we think of reporting the challenges to protect people, but there's also just life issues that need to be handled. And I appreciate what you've done there. Thank you.
Thank you, Representative Keel. You do important work, Ms. Hennen, so we're very grateful that we're able to bipartisanly approve more positions for you. And I know you're going to continue to do good work for the people of our state. So if you'd like to continue your presentation, please do so.
Thank you, Madam Chair, and thank you, Representative Keel, for sharing that experience. I will come back to this committee at any time that I am invited, but I have a whole host of examples that will show evidence to the problems that are out there. But to Representative Keel's point, how we are able to make life improved, and in also to consider the cost savings in terms of when you improve people's lives, they may not need more intrusive, expensive care. But we must never minimize what happens to the well-being of people when they are separated and cannot be connected. And I applaud you, Representative Keel, because you were such a good advocate for this couple that wanted to be together for their wedding anniversary. So many people did not spend wedding anniversaries, funeral time together, graduations, the list goes on and on and on. So I promise to try to stay within my time frame. Please, Madam Chair, let me know when it's time to kind of move on. But I will also say that there are very good stories out there. This slide here is I had to make the very difficult decision in March to temporarily transform Ombudsman services to a virtual presence. And I did so in order to do our part to mitigate the spread of the COVID virus. And so we have been working, yes, but we've been doing so virtually up until October. And the slide does list what did not change. And what I want you to also understand is my commitment to ensure that we are also tracking and recording emerging trends. Next slide, please. So this picture was actually sent to me. I believe it was April, May, and it was very troubling. And it was not sent to me for a sensational type effect. This was actually a nursing home resident who put this poster in their window, and on the bottom that's cut off, it reads, "Set us free." And it is a very much a symbol of how residents report to us that they feel like prisoners, yet they are not prisoners. And I share this with you because I know all of you are very aware of how COVID-19 has affected people in long-term care settings. So to receive something like this for me was quite symbolic, but yet very, very sad. Next slide, please. There are a number of trends that are emerging out of COVID. So I will touch on the top three, but there are more. As we've mentioned, it is no secret that one of the biggest challenges for people has been the restrictions on visitation and people separated from family members and loved ones. Visitor restrictions placed on people since mid-March meant to protect them reveals unfortunate consequences that isolation and loneliness creates. What's being reported to us from residents is there's nothing to do here. I am isolated to my room. There are not enough staff to get the work done. We've heard from many family members because also people in memory care units are particularly vulnerable to the isolation effects that COVID has created. So not only do we see the high death rate that COVID-19 has wreaked havoc, but we also know that people, particularly in memory care units, have suffered greatly from the isolation, and through tears, we know that many people are reporting to us that their mother, their father no longer recognizes them. And also, what we did have much work on, of course, is making sure that if people cannot be together, that they get to place a camera. The law about electronic monitoring, we do know that people were able to get cameras placed during this time. We have family members that really, pre-COVID, they were the people providing the care through their consistent visits. So without that, what we were able to see, unfortunately, is first of all, at least half of our calls have been about isolation and loneliness, but also, unfortunately, many reports were received about the neglect of care, such as missed meals, missed personal cares, and injury. Now, I will state to you, there are many good providers out around the state of Minnesota, and we must commend all of them for daily. They show up. Daily, they do show up. But we also have to acknowledge that there are problems. Transfer discharge. So what I share with you on this slide is complaint comparisons from, so this is federal fiscal reporting year, 10/1/2019, 9/30/2020. You can probably tell I'm right in the throes of the federal government reporting right now. We are putting our federal report together. 445 increase of reports of transfer discharge from 178 over last year. 244 of the 445 complaints occurred since COVID-19. Another 70 discharge complaints received from October 1 through December. The good news is Governor Walz issued the Emergency Executive Order 2014 on March 23rd, 2020, which prohibits property owners and landlords from filing eviction actions and terminating residential leases with only narrow exceptions. So this order is the primary reason that we have been able to stop any involuntary transfer discharge action. So this keeps people in their home. We also, this is where I have been pleased with how we have worked with other state entities, state agencies, such as the Attorney General's office, in order to prevent people from being involuntarily transferred, evicted, some to the streets. And this emergency executive order has prevented a lot of that from happening. Staffing, we heard from the health department about staffing. Certainly, COVID-19 has greatly exposed the problem of inadequate staffing. We receive so many calls from people. They worry about not enough staffing. They worry about the staff themselves becoming sick. I will suggest to you that I do see that this is an area where we all have an opportunity to come together and work together and figure out what we can do to improve this. Frontline staff in long-term care settings do need better support. Residents cannot survive without adequate, sufficient staff. And this is a conversation happening also at the national level. I suggest to you, we do need to see improved wages and guaranteed benefits such as medical and sick leave pay. We are hearing trends around the state that more residents are saying yes to the vaccine and less staff. And part of that reason is they worry that they will become sick. This is what staff report to us. They will become sick from the vaccine. therefore not be able to come to work, and they do not have medical or sick leave pay. So that's because we too are asking the question, why so many staff as compared to residents are not receiving the vaccine. Next slide, please. In conclusion, I leave you with my recommendations for today. We need to organize our care systems around the people who live and work in long-term care settings to enhance quality of life. We need to focus on equity and inclusion, free of discrimination. We need to continue to support and allow residents of long-term care settings regular in-person contact with loved ones of choice during the COVID-19 pandemic. And here is another area where I report to you that we do more together than apart. And so the Ombudsman's office has played a very important role in working with our partners, including our partners in the Department of Health, in terms of ensuring that we balance safety with allowing people the right to visitors. Staffing, I've already talked about staffing. I also support the fact that we need to continue to assure access to adequate PPE, COVID testing, and lastly, uphold the commitment to transparency and regular communication. There is a resident advocate newsletter that is written for and by residents of long-term care facilities. And a common theme in that newsletter since March has been that in the midst of all of this, what is one important thing that you need to be doing? And that is that we need to stay connected. We need to be able to ask questions, and we need to be able to receive answers, the right answers. And I'm here to tell you that I am committed to being transparent. For example, how are we spending our COVID money? I'm also here to tell you that I'm committed to a regular communication with this committee in order that you know what is happening on the ground, what is taking place. Some very amazing people live in our long-term care settings, and I know that you all know that. Next slide, please. I wanted to end with a glimmer of hope, because I am receiving calls from residents, and it's probably the hardest call to take. And that is people saying, please tell us this will end. They actually call me and ask that question. This is no exaggeration here. Through their tears, please tell us this will end. Please tell us we will not live like this forever. And the answer is no, we will not live like this forever. There is hope. Minnesota is a front runner. Minnesota is a leader. I will tell you this from a national level of state ombudsman. People look to Minnesota. What is Minnesota doing about visitation? What is Minnesota doing about vaccinating and making sure everyone is vaccinated? How are you prioritizing? So we are looked to for what are we doing here in the state of Minnesota? But we must make sure that we are constantly looking for how people are doing within our long-term care settings. And I do want to leave you also, there's ombudsman staff are resuming in-person presence. We did start with outdoor window visits in October, and my staff are starting to go back into the actual settings themselves with our safety as our guideline. I wanted to leave you with some positive resident feedback. I'm kind of going to skip around the state, and I don't have enough time for all areas, but Rochester, the Rochester area, within the Rochester area, residents report the vaccine that's being administered, it's going well. It's like thumbs up. And administrators are very excited. However, more residents are consenting to the vaccine than staff. Within the metro area, facilities are sharing their plans about vaccine distribution. What we are seeing is questions about if a person is going from the hospital to a nursing home for transitional care, which means short-term stay, they want to be vaccinated. However, the facility has already completed their vaccination. But what we are seeing is physicians from the hospital and staff are stepping up and saying, we want this individual vaccinated. They are in your setting. Tell us what we can do to help. So it's crossing over and working together. Northwest Minnesota. It was amazing because I asked all my staff to send me reports of what they're hearing. And so the list of facilities that actually are receiving the vaccination. Again, more residents than staff are being vaccinated. What we are seeing in some areas is more staff are needed at some locations in order to monitor the residents because people must be monitored for a certain period of time after they get the vaccine. So I see that as hope, but there's still a lot of work to be done, right? Because there's a lot of information happening and changing every day. We are receiving many calls from people who live in senior high-rise independent living settings, asking us, I'm over 65, please, when can I get my vaccine? Or people living in independent living apartments within a continuing care campus. So there's independent living, assisted living, and skilled. They see people on their campus vaccinated. Can we be vaccinated, please? We also are hearing of people who are in independent living and somehow something happened along the way and all of a sudden their groceries are not being delivered to their doorstep and they're in need of it. So Ombudsman have actually reached out and we are making that happen. We are even making sure that people are getting their groceries at their doorstep as they were. My staff are doing excellent work. It's not easy. We are at times, we meet on a regular basis because pandemic fatigue has set in, but we are doing well and we are getting much work done. With that, that ends my presentation. Last slide will show you my thank you and my contact information.
Well, thank you, Ms. Hennen, and we're so grateful for you and your staff. You are doing wonderful things for the people of the state. And you've highlighted many issues that I hope our members will start working together and tackling. And thank you for highlighting all of those issues we need to solve as a state. And it's good to hear that Minnesota is leading the way and people are looking to us as we tackle the COVID pandemic and other issues in long-term care. And I see that Representative Albright has his hand up. Representative Albright.
Thank you, Chair. Ms. Hennen, I'll be quick because I know the time is limited. First is just a request for a definitional difference between a long-term care facility, of which you describe yourself as the ombudsman for, and how does that contrast with an assisted living facility? There is talk about the plurality of those, but I'm hoping that you can provide a distinction between the two for us. And I have just two quick follow-ups, Madam Chair.
Okay, Ms. Hennen.
Madam Chair, Representative Albright, thank you. That's a very good clarifying question. I'm glad you called that out. So within our scope of authority is nursing homes. It's defined as nursing homes and other adult residential care settings. So assisted livings fall within other adult residential care settings, even though to some people, we know some assisted livings have memory care units. and people who live within those units meet skilled nursing facility level of care. We could have a long day, and I will not do that to you, but in order to define a distinction, also assisted living is in most cases a lesser restrictive living environment. And so the way we look at this is long-term care settings include nursing homes, and then assisted livings fall under a category of other adult residential settings. I hope that makes sense.
Yes, thank you.
Representative Albright.
Thank you, Madam Chair. Ms. Hennen, I'll couch the last two questions together so that you can respond. You mentioned in one of your needs on one of the slides in your deck, a need for additional frontline support staffing. I'm wondering if you could articulate what types of frontline staffing are needed. Is that RNs? Is that CNAs? What type of frontline staffing deficits are we facing? And then you also on one of your very last slides said that we want to organize, or your desire is to organize care systems around the people. And I'm just asking for your depiction in terms of what does that mean and what does that look like? And I'll end there. Thank you.
Thank you, Representative Albright. Ms. Hennen.
Madam Chair.
Thanks for offering. I've got several in my briefcase already.
Go ahead, Ms. Hennen. Sorry about that.
That's okay, Representative Albright. Very, very good questions. So I will start with your last question, which talks about organizing our systems around people. And so what I mean by that is it's really been a transformation over the years to move from a medical model to a person-centered model. And any of us who may have accessed the healthcare system, particularly with people 60 or older, understand that those systems may be more built around clinical, medical, instead of putting the person first and acknowledging who the person is, what the person's needs are, and what their preferences are, and listening to them. All of us know that too often ageism reaches inside, and there are particular ageism, racism, there are so many things that assumptions are made and the person's voice is lost. So that's where I'm going with that. And you raised such a good question about staffing. What do I mean by that? According to CMS, which is the Center for Medicaid and Medicare Services, the national average of certified nursing assistant hours per resident per day is 2 hours and 23 minutes. The federal government studied this issue and concluded that residents need 4 hours and 6 minutes of care per day. That translates to 2 hours and 48 minutes from a certified nursing assistant, 33 minutes from an LPN, and 45 minutes from an RN. This is the minimum amount of care needed to prevent pressure ulcers, dehydration, losing the ability to carry out tasks. So I quantify that for you to understand how that covers our frontline workers. At a national level, there is advocacy to increase the certified nursing assistants. But I think in Minnesota, we really need to take a look at our data and really understand, what are we talking about? All of the frontline, or where do we start? So your question is very welcomed.
Thank you, Ms. Hennen. I'm not seeing any other questions. So members, we will be meeting next Tuesday at 10:30. You will get the agenda sent out this week. Next week, we're going to talk about MFIP, TANF, PCA rate setting, and assisted living licensure and rulemaking. So we'll have a full deck next week to tackle and do some background information before we get starting to hear bills that are sent to this committee. Does anyone have any questions or comments before we adjourn? Not seeing any. Okay, so the meeting's adjourned. Enjoy.